All right, welcome back. This is lecture 6, last lecture, yay, of airway management. We have gone through a lot of slides. This last section is going to go over some of our different types of airway adjuncts or advanced airway adjuncts. First one we're going to talk about is the King LT. That's the King LT airway. It's a supraglottic airway device. King LT is latex free. It's single use, single lumen type of airway. It's blindly inserted into the esophagus, and it can be used to provide positive pressure ventilation in patients that are apneic. Maintaining a patient airway in spontaneous breathing patients who require advanced airway. It's in adult and pediatric sizes, and we can use our end-tidal CO2 with it. It's curved tube with ventilation ports between the two inflatable cuffs, can be inserted very easily. You've got the patient in a inline neutral position. You slide it in, inflate one cuff, and you're done. Two types of King tubes, the LTD and the LTSD. King LTD can be used in adults and children. King LTSD can only be used in adults. There's 5 sizes of each type based on the patient's height or weight. Each size has a different color and a proximal connector and requires different cuff inflation pressures. The King LTD and LTS share most of the same features. Both have proximal pharyngeal cuffs, distal cuffs, and several ventilation outlets. In both, an ET tube introducer, a gum elastic bougie, can be inserted through the tube. The distal end closed in LTD, open in LTSD. So the open LTSD, allows you to put a suction catheter down in it and suck out gastric contents. Indications and contraindications. Indications, it's an alternative bag valve mask ventilation when a rescue airway device is necessary. Same considerations as a combi tube. The contraindications in patients with a gag reflex is not going to work. You're shoving this down, they're going to gag all over the place. Patients with known esophageal disease or patients who have ingested some kind of caustic substance. Complications, laryngeal spasms, vomiting, hyperventilation, trauma from improper insertion technique. The pharyngeal balloon may push the epiglottis in the glottic opening. Now, I will tell you there is another complication. I have seen them where the tip of it will actually collapse and curl. You need to absolutely make sure that that does not happen. You need to make sure you got chest rise when you're bagging your patient. You need to make sure you're getting capnography when you put the capnograph on it, your waveform, because you got to be picking up end-tidal CO2 with this. Once you've sealed off that esophagus, you should have access to your trachea. You should be ventilating properly. Insertion technique, patient's height and weight determine the size you should use. You'll be doing this on skill drill 1515. The laryngeal mask airway, or LMA, they're an option for patients who require more support than a BVM. They don't require ET intubation. They provide a good conduit for glottic opening, and it's a less invasive procedure. It's used a lot in outpatient stuff, like you're going to have a colonoscopy or something that's going to be outpatient type of sedation where they want to secure your airway. It surrounds the larynx opening with inflatable cuff. Cuff conforms to the airway and contours to form a very airtight seal so you can ventilate. Indications, contraindications, alternative to bag valve mask ventilation when the patient cannot be intubated or you're not going to want to intubate. It's less effective in obese patients. Pregnant patients and patients with hiatal hernia are at an increased risk for regurgitation. Ineffective with patients requiring high pulmonary pressures. It's better ventilation, than just using a BVM. No continual maintenance of mask seal, no laryngoscopy, less risk of trauma, protection from secretions. Disadvantage is no protection against aspiration. Air may be insufflated into the stomach, and it's not a primary airway in emergency situations. Some of the complications, regurgitation and aspiration, hypoventilation, patients who require high ventilatory status, upper airway swelling has also been reported. The equipment, they come in a lot of different sizes. They consist of a tube and inflatable mask. There's 2 vertical bars opening in the opening, preventing any occlusions. Proximal end of the tube is fitted with a standard adapter. All right, so there you go. That's what it looks like. Cuff is a one-way valve. 6.0 ET tube can also be pass or with size 3 or 4 LMA, therefore facilitating your intubation because it's blocking off the esophagus. Fast trach LMAs guide the ET tube into place into the trachea. So they're kind of cool. This figure shows examples of the different mask airways, the LMAs. Eye gel, that came on the market just recently. It's inserted in a similar manner as the LMA. Creates a non-inflatable anatomic seal. These have become very, very popular lately. You just, you don't have to intubate. You can just put the eye gel in. As long as you're ventilating, you got chest res, you're doing good. It's alternative when intubation is unsuccessful. So if you've got 3 failed intubation attempts, you better be getting your eye gel in there and ventilating. Features, as an integral bite block, you can't bite through these things. Gastric access is also on the side. You can pass a 12-French gastric tube down in there to suction out any gastric contents. Supplemental oxygen and inlet port for passive oxygenation, and also a support strap to secure it. Here's your eye gel, and also there's a chart up there, 15, 18 sizes, and patient criteria for eye gel supraglottic airway. They come in all different sizes, all the way down to infant. All right, so Cobra Paralaryngeal Airway. It's a shape type of device. Easily slides along the hard palate. Holds airway soft tissue away from the laryngeal inlet. It comes in 8 different sizes. It's named because of the cobra shape of the distal part of the airway. It allows the device to slide easily along that hard palate, and it's available in several different sizes. Indications, usage, similar to other supraglottic airway devices, and it can be used in pediatric patients. Contraindications, risk of aspiration, and massive trauma to the oral cavity. Other complications, laryngeal spasms may occur with an intact gag reflex. If not serted far enough, the inflation of the cuff may cause tongue to disrupt the adequate seal. Patient cannot be ventilated if the device is too small. Insertion. Well, deflate the cuff completely, apply a water-soluble gel, open the airway, and insert the distal end. Advance until modest resistance. Inflate the cuff, but do not overinflate. Ventilate the patient and use waveform capnography. There you go. There's a look for the placement. This figure shows how to insert the Cobra, how it goes into place. Other multi-lumen airways. Multi-lumen airways, combi tubes, insert blindly. Really don't use those very much anymore. They're clinically just not out there, but in some countries they're still being used. Clinically proven to secure the airway and allow for better ventilation than a bag valve mask and a simple airway adjunct in most cases. Contains 2 lumens. That's why they call it a multi-lumen airway. Each lumen has a standard adapter which accommodates for any ventilation device. Can also contain an oropharyngeal balloon, which eliminates the need for a mask seal. There you go. This figure shows the example of the combi tube. Indications: unresponsive, intubation whom intubation is not possible. They have to be older than 16, patients between 5 and 7 feet tall. Contraindications: esophageal trauma, known pathological condition of the esophagus, patients who have ingested any kind of caustic substance, and then a history of alcoholism because of the risk of esophageal varices. All right, so advantages: ventilation of the esophagus or trachea, inserts easier than an ET tube, minimal cervical involvement or movement, no mask seal, and airway patency. Some of the disadvantages, obviously the wrong port results in no pulmonary ventilation. It is temporary, there is a risk of aspiration, and intubating the trachea via direct laryngoscopy is challenging. All right, complications, unrecognized placement, when it goes into the esophagus and we're not ventilating properly, laryngospasms, pharyngeal or esophageal trauma. Ventilation may be difficult with pharyngeal and balloon pushes the epiglottis over. Here's your insertion of technique. Combi tube, you have a single tube with 2 lumens, 2 balloons, 2 ventilation attachments. For insertion, check and prepare your equipment. Make sure to pre-oxygenate your patient. Do not interrupt ventilation for longer than 30 seconds to insert the airway. Head should be in a neutral position. Insert the thumb into the mouth. Insert the device until the incisors are between the 2 black lines. 2 valves must be inflated sequentially. Combi tube consists of single tube with 2 lumens, 2 balloons, and 2 ventilation attachments. Before insertion, make sure you prepare all that equipment and get it done and make sure that the cuffs are working. Once you get it in, you're going to displace the jaw, put it in where it meets the 2 teeth, inflate both of your balloons, and then after they've been inflated, you're going to start ventilating. You'll ventilate the first one first, and if it doesn't work, you'll move to the second one. All right, surgical and non-surgical cricothyrotomy. When all else fails, we can get into this stuff. This is not something you want to do. not us medics that have been around for a long time. It's the bottom of our list. It's just not a cool thing to do, but you can do it relatively easy and get it done. But I mean, don't be afraid of it. I mean, but you just don't do it that often. Open or surgical cricothytomy and translaryngeal catheter ventilation, non-surgical or needle cric is what we're talking about here. You need to be familiar with all your anatomy and physiology. Know how to find the cricothyroid membrane because that's where we're going to go, whichever procedure we're going to use. The open cricothytomy, also called the surgical cric, involves incising the cricothyroid membrane with a scalpel after you've cut the skin. You incise the cricothyroid membrane and you're going to insert an ET tube up there. Cricothyroid membrane is the ideal site for the surgical opening for the trachea. There's no important structures that lie in between there. Okay, several different types: open surgical, modified cric, the cell dinger technique, and a device that functions used with the introducer. I mean, you get a 4.5 or a 5.0 tube, and you just make your incision, and you open up the incision from the cricothyroid membrane, and then just slide the tube in. Scalpel and the right size ET tube, and some 4x4s and that kind of stuff, and obviously tape it in place. It's not that difficult to do. Indication: patient airway cannot be secured with conventional means. This gentleman here has massive facial trauma. Okay, he probably got swelling of the face and the mouth. Severe foreign body obstructions that cannot be extracted with the McGills, airway obstructions from swelling, massive maxillofacial trauma, the inability for the patient's mouth to get open. Contraindications: you can't secure the patient's airway, inability to identify correct anatomic landmarks, okay, crushing injuries to the larynx or the tracheal transectioning, underlying anatomic abnormalities, age younger than 8 years old, because the larynx of a small child is generally unable to support a tube large enough to produce effective ventilation without causing damage to the larynx. In situations in which a cricothyrotomy is indicated, the patient must be rapidly transported to the closest facility. Here's your advantages and disadvantages of your open cric. I mean, advantages: it can be done very quickly. You can get the airway and get them intubated. Disadvantages: it's kind of difficult to perform, especially in children. Maybe more difficult than needle crics. Complications: bleeding. God forbid you hit the jugular vein or something when you're cutting. Risk of perforating the esophagus and damage laryngeal nerves. Taking long time to get this done is going to cause unnecessary hypoxia, so make sure you're ventilating your patient in between. Then subcutaneous emphysema from tube misplacement. Open thyroid equipment: scalpel, ET, or tracheostomy tube. 6.0 is your minimum. So in your adults, you need to get that 6.0 and make sure that that's what you're using, because it's going to be big enough. You can get it in there. Commercial device or tape for securing the tube, curved hemostat, suction apparatus, sterile gauze pads for bleeding control, and a BVM. Technique: must proceed rapidly yet cautiously. Identify the cricothyroid membrane by palpating for the V-notch of the thyroid cartilage, which is the high, sharp bump. When you have located that V-notch, slide your index finger down into the depression between the thyroid and the cricocartilage, which is the membrane. Males have more prominent thyroid notch than females. When palpating the anatomy in females, first locate the cricoid ring, then the cricothyroid membrane, and finally the thyroid cartilage. Your partner should prepare the equipment, ensure the cardiac monitor, maintain aseptic technique when you cleanse the area with iodine. While stabilizing the larynx, make a 0.5 to 0.75 inch or 1 to 2 centimeter vertical incision over the cricothyroid membrane. Insert the curved hemostats into the opening and spread it apart. Gently insert a 6.0 cuffed ET tube or a 6.0 tracheostomy tube shyly. I love the 6.0 shylys because they're so much easier, and you blow the balloon up and it's right there and it's stable. That's why we keep them in our aircraft. Inflate the distal cuff when appropriate air volume. Attach the bag valve mask, confirm placement, ensure bleeding has been controlled and secured to ventilate. Needle crics can be done 14 to 16 gauge over the needle catheter, but you need a high pressure jet ventilator. Okay, it's jet insufflation. If you don't blow it in through that 14 gauge, you're really not going to do a whole lot. There's your indications and contraindications. It's about the same that you're going to do for surgical cric. Advantages and disadvantages are the same. Complications, you got to be careful in proper catheter placement. You may go too far when you're doing your insertion. Excessive air leaks, too much air infiltrates into the subcutaneous space. Extreme care has got to be exercised when ventilating with a jet ventilator. Release the valve should be open just long enough for adequate chest rise. Overinflation of the lungs can result in your barotraumas. And underinflation can lead to hypoventilation. Needle crike, large bore catheter, 14 to 16, 10 cc syringe, 3 cc sterile water saline, oxygen source at 50 psi, and a high pressure jet ventilator device and oxygen tubing. Here's your technique. Drop about 3 cc's of water, place the head in neutral position, locate the membrane, and if time permits, cleanse the area with iodine or some kind of chlorhexidine. We don't really use iodine very much anymore. Stabilize the larynx and insert the needle into the midline about the cricothyroid membrane at a 45-degree angle. After that pop is felt, insert the needle approximately a ½ inch or 1 centimeter further, then aspirate with a syringe. If it's incorrectly placed, when you aspirate your syringe, you'll get bubbles because you're sucking air now. So you're in the right place. Advance the catheter over the needle until the catheter hub is flush with the skin. Then withdraw the needle and place in a puncture-proof biohazard container. Attach the other end of oxygen tubing on the high jet insufflator. Begin with ventilations by opening and releasing the valve of the ventilator. Turn and release the valve off with chest rise and secure the catheter in place. All right, folks, that's the end of this lecture. That's the end of Chapter 15, Airway. You're going to clock out now and go ahead and do the Quizlet. There'll be a singular Quizlet for Chapter 15. And we will see you next time. Thank you for watching.